Thank you. Is this working? You can hear me okay?
No.
How about now? Yes? No? A little higher? Higher?
Is there a volume?
How about now? Let's see. Is it turned up? Try to turn it on. It is on. Middle. Talking about wrong. Okay, hopefully you can hear me now. Yes? Perfect. All right, great. Well, thank you. Very happy to be here. So Preferred Therapy Solutions, we are a therapy provider. We service long-term care facilities, short-term rehab facilities all through the Northeast. I've been with the company since we started back in 2004 and kind of worked my way from a clinical treating therapist role into management operations. And really for the last 3 or 4 years, I've been focusing in on strategic planning and development for ourselves, and more importantly for our customers, our partners out in skilled nursing. Healthcare is changing and changing rapidly. With payment reform, regulatory reform, it's just really Medicare is hitting the skilled nursing sector very hard with all kinds of new regulations and changes. And really part of my role, what I do for our company, is to help keep us on top of all those changes so that we can continue to provide a good quality service to our customers and to our patients. But also to educate and kind of do talks like this to groups about different changes that impact us, from QRP, quality reporting program, to the value-based purchasing, and really most importantly this year has been the patient-driven payment model. Hopefully most folks here are aware of what the patient-driven payment model is. It is impacting us coming this October on our Medicare Part A patients in skilled nursing. And it's a payment reform. It's how we get paid for the services we provide to our patients who are covered under Medicare Part A skilled stay. So as I go through the presentation, I'm going to quickly go through an overview of PDPM for those folks in the audience who may not be too familiar with it. Hopefully by now most folks are, but really just talking about how it changes the structure and how we get paid. And really what I want to focus our time on today is the ICD-10 coding, diagnosis coding, and non-therapy ancillary capture. All these clinical areas and diagnosis and conditions and services that are going to drive reimbursement under the new payment model that don't matter so much today under the RUG-based model we get reimbursed by, but are going to really be critically important that we understand what they are, how they impact reimbursement, and what we need to do to be ready to capture these as we transition from one payment model to the next. And we'll kind of end with a couple ideas on strategic planning, how to get ready for PDPM. Hopefully most of you in the room here already, if you're in skilled nursing, you're practicing some of these already. If you're not, we've got to get going because we've got about 51 days until this takes effect. And then I'll take a look at just some early results in terms of what does the PDPM impact look like from a financial perspective. What we've been doing is asking our customers, our partners, to send us their files electronically. We can upload them into our system, our software system, and take a look at, all right, this patient today under RUGs is reimbursing at a set number of reimbursement. What does it look like for that same patient under PDPM? To get an idea of, how is the facility going to fare financially under this new payment model, but more importantly, take a look at what are the areas of capture that maybe we need to focus in on to help improve that. So please feel free as I go through the talk today, ask questions, interrupt. If I sit here for an hour and talk, you might all fall asleep. If you ask questions and get involved, it'll be a lot more interesting for everybody. If I go too fast, please slow me down. Like I said, I'm going to kind of go quickly through the what it looks like in terms of the payment model. So last year, in the final rule for fiscal year 2019, Medicare put out there that we're going to change the payment model from RUGs to PDPM. They made some minor changes in April when they released a proposed rule to the different rules. Okay. And then just recently, a week or two ago, they finalized all the changes to PDPM. So what you're seeing and hearing today is as up to date and current as of about a week and a half ago when Medicare finalized the rule. This all takes effect in October 1. And what's important to note here is that there's no transition period. So September 30th, your patients are being reimbursed under a RUG-based system. October 1st, it changes to PDPM. All facilities have to reassess their patients between October 1st and October 7th to get them from a RUG category into a PDPM group. So a lot of training, a lot of transition, needs to start occurring in late September relative to, how we're capturing our patients for reimbursement purposes. And this is the biggest change to Medicare since they adopted the RUG-based system about 20 years ago. Real quick, why is Medicare making these changes? Long story short, Medicare has for a long time not liked their payment system for SNFs. It's not accurate. You can have a patient that has multiple surgeries and complexities from nursing being reimbursed the same as a very straightforward, uncomplicated, not many medical complications patient that is in your facility. And the reason for that is that the majority of days today in the nursing home are reimbursed based upon how much rehab services they get. How many minutes of therapy, how many days of therapy, and what's their ADL score. That's what drives reimbursement today. And Medicare says that's not accurate. We need to base this based upon patient characteristics and try to use it, try to reinvent the wheel and come up with a better payment system. And it doesn't account for non-therapy ancillaries. We'll go into what that means a little bit later, but these are just conditions and services the patient needs or has that really drive up cost. And there's no specific way that the RUG-based system reimburses facilities for that. And most importantly, in terms of the bottom bullet point, which is this is just the first of one change in payment, and then in probably 3 more years, maybe 4 years, we're going to have another change. We're going to go from this system into the unified post-acute payment system. This is where they're going to look at payment for SNFs, inpatient rehab facilities, long-term acute care hospitals, and home health, and rebase how we're getting paid in all 4 of those settings, with the goal that Medicare wants the patient at the right setting, at the right time, for the right cost. They're trying to move patients, out of the high-cost settings, from the acute care hospital into a post-acute setting. And certain patients today are being discharged from a hospital to an inpatient rehab, but maybe they should be discharged to a SNF at a lower cost. Or they're being discharged to a SNF, and they really could be home with home health services. So Medicare is looking at kind of how can they realign the payment systems between those 4 different post-acute markets or settings to make it equitable and really reimburse fairly based upon where the patient is, based upon their characteristics, not necessarily what setting they're receiving services in. So their goal with PDPM is to create a system that pays facilities more accurately based upon patient complexity and conditions. They want to address concerns that Medicare has heard from MedPAC, which is an advisory committee that advises Congress, and they submit monthly reports to Congress, and they've been advising Medicare to revise how they pay skilled nursing, as well as home health and other services, because they think that there's just our industry's fraught with waste and abuse, and everything is based upon making more money and not based upon patient care needs. And finally, they want to make the system easier. Currently today, for anybody in here who's familiar with the MDS system, we're looking at a 5-day, 14, 30, 60, 90, end of therapy, change of therapy, start of therapy. You're looking at 8, 9 different assessments that folks have to do in nursing homes to get paid. It's a crazy complex system. It requires us sitting behind a computer looking at what's today's date, how many minutes did my patient get, are they going to hit their RUG category or not. So we're spending more time trying to determine how many minutes of therapy a patient got than really what does the patient need. What are their conditions. And so the Medicare wants to make it an easier system, less assessments, all based upon patient condition. So this for me is the most important slide in terms of understanding the structure of how we're getting paid. It compares how we're currently getting paid under the RUG-4 model compared to how we're going to get paid under PDPM. RUG-4 is an index maximizing system, right? You guys are a case mix state, so hopefully you're familiar with case mix. You get a case mix score for therapy, and you get one for nursing. Whichever one pays higher is what you bill Medicare. 90% of the time, it's rehab. Okay, so 90% of our Medicare days are being paid based upon how many therapy minutes a patient is getting. Under PDPM, that changes drastically. It goes from a case mix maximizing system to a case mix combining. So now we're breaking out every disciplining component, adding them together to get your reimbursement. And the 5 different disciplines or components are physical therapy, occupational, speech therapy, nursing, and non-therapy ancillaries. Those are the 5 case mix adjusted components that combined together are going to determine how much your reimbursement is in a facility, and they're all based upon patient characteristics, not based upon how much therapy they received, not based upon how many days of therapy they received it for. It's what is the patient's diagnosis, what's their condition, what do they need, and that's what's going to drive reimbursement. So it eliminates the need to provide unnecessary care and really look at your patients clinically. That's the goal, and it really, I think, to a large degree, it does achieve that goal. Any questions on that? Once, twice?
Can you give me an example of a non-therapy ancillary?
Yeah, I will. Actually, we have a good chunk of the presentation later on is going to go over non-therapy ancillaries. And I do have, I just updated them. I can send them out and then they can get distributed, the whole list of every single one that's currently going to qualify come October. I'll send that out to Christina and she can send it out to all attendees so you have a copy of it. Again, this is payment reform, payment change. This is what the rates look like. So if we kind of look at the urban market, you have your nursing, NTAs, PTOT, speech. These are the 5 case mix adjust components per day. This is the reimbursement. These are going to be adjusted up or down depending upon what they qualify for, but this is how the payment is constructed. So you're adding all these together, plus a non-case mix, which is just to cover some overhead and ancillaries. And that's what's going to drive reimbursement. And what's interesting here is that you have urban and rural. In the urban market, nursing and NTAs reimburse higher on a daily basis than they do in a rural. But in the urban markets, you're going to have PTOT speech are reimbursed much lower than what you're going to get in a rural market. This is based upon resources, costs, how Medicare does their algorithm stats, all that kind of stuff. But that's how they're, based on how they're doing it. Therapy is valued higher in rural markets, and nursing is higher valued in urban markets. Medicare believes this is going to be budget neutral. Medicare is wrong quite often, and they're wrong on this. This is going to be far from budget neutral. I do believe that when folks are already getting very smart and they have the data and softwares to really help them drive reimbursement, and they're already doing it. This is going to, I think, what they're budgeting, I think it's going to be blown out of the water, and in about a year, there's going to be a massive correction in terms of rates. This happened years ago when Medicare did some changes to how they reimbursed on the drug-based model. They really had a forecast error that they call, and every year, per statute, they have the ability, if they forecast error, they can take it all back. So I think Medicare will do that, come next year, and we'll see some, downward shifts in terms of our reimbursement. But it is what it is. We'll see what it looks like as we get into it. This is a lot to see on one slide from way far in the back. But these are the 5 different case mix adjusted components: PTOT, speech, non-therapy, ancillaries, and nursing, and what determines payment. Okay. So for PT and OT, they each have their own CMI. They each have their own reimbursement. But what drives that, or what determines that, are the same 2 things. What's the primary reason they're in the SNF, so primary diagnosis, and then what is their functional status? Currently today we're looking at ADL scores. It changes from ADL scores to functional status, functional scores based upon section GG coding on the MDS come October. So those 2 factors determine how you get reimbursed for PTOT. It's only 2 things looking at it. And then the last piece for PTOT is a variable per diem adjustment. So what Medicare did is they looked at how much therapy does a patient get from day 1 to day 100, and they noticed that over time the PTOT services gradually declined. So they're going to start taking away some of that reimbursement on day 21. And I'll go over that in just a couple minutes. Speech has a few more components or determinants of payment. Diagnosis does count, but also cognition, swallowing disorders, altered diets, and speech diagnoses or speech comorbidities. So 5 different areas are going to impact your speech reimbursement. So it's a little more complex than PT and OT because there are 5 things you have to look for, but it's straightforward because the more you capture, the higher the reimbursement. PTOT is a bit more complicated because of how it all plays out. But for speech and non-therapy ancillaries, it's all about the more you can capture, the higher the reimbursement. Pretty straightforward. Nursing, nothing is changing significantly for nursing. It's all about the clinical presentation of the patient. So they're keeping the same types of categories they had under the RUG-4 model. They're just condensing them. They're kind of combining a couple of categories together based upon functional score. But it's all about their clinical information, their functional status, presence of depression, if they have restorative nursing services, are really the key drivers of the nursing reimbursement. And then the NTAs, comorbidities present, extensive services received. So comorbidities are certain diagnoses that the patient has that are typically costly to care for, or they require more resources in nursing care to care for that type of patient. So you're looking at certain kinds of wounds, diabetics, morbid obesity. You're looking at certain respiratory illnesses like COPD, asthma, those types of things that are just a bit more involved and may require more care. or patients who are on IV medications. And we'll go into these a little bit later as I do cover NTAs in more detail. So as you can see, there's the 5 adjusted components. It's all about condition, diagnoses, coding is what's going to drive reimbursement. And the ability to capture this information right from admission is going to be critically important.
What trigger? Can you go back a slide?
I can't go back.
Oh,
sorry.
what trigger?
I was advised not to, or it's going to ruin everything. Yeah.
Start over.
What in the MDS triggers? Now I'm not going to remember.
Extensive services.
Yeah.
Under nursing.
Yeah.
So for nursing, extensive services are 3 things. It's patients with ventilators, trachs, and infection isolation. So just 3 areas, and that has the highest reimbursement because they have the highest cost. And it's always been that way. Nothing changed from their prior regulations on that, but it's just those 3 qualifiers.
Okay.
And then nursing, I don't go into nursing in great detail here, but they have special care high, special care low, pretty complex are the 3 other major categories for nursing that have good reimbursement. And it's all like patients who have septicemia, respiratory type illnesses, certain, there's a whole long list of things that qualify for those. And then there's a few other categories for nursing as well. But it's all the same rules apply. Yeah, Medicare hasn't changed the rules, the regulations. This is just about payment, right? So this is how we're getting paid for services. So the VPD, or the variable per diem adjustment, impacts PT, OT, and non-therapy ancillaries. I already kind of described PT and OT, but for non-therapy ancillaries, so again, this is to cover cost of meds and the different conditions, wounds, and that type of stuff. What Medicare says is that, hey, the cost hits a facility upon admission, right? Because you got to have all that stuff ready, set, go when your patient walks in the building. So they are going to pay you up front for those costs. So for Medicare days 1, 2, and 3, you're going to classify your patient into their NTA group. You get a certain CMI, right, for that. You multiply it by 3, and that's going to be your reimbursement. So you're looking at daily rates for NTAs of $300, $400, $500, $600, maybe $700 a day on day 1, 2, and 3, just for the NTA component. And then starting on day 4, it's going to drop down to whatever category they're in, and whatever that CMI score looks like is what you're going to get paid. So really important that folks understand that and they capture that information upon admission so that you can get credit for it, because it's really, for me, when I've done all the analysis, looking at all the numbers and stats and financials, the NTA capture has the biggest impact on a facility's success or failure. Nursing is important, speech is important, but people right now today, facilities right now today are not capturing very well on the NTA piece. And that needs to change in order for them to be successful financially and afford to care for the residents that we treat.
So, quick question.
Yeah.
So in our facility, they were noticing that a lot of patients come on Friday, and then there might be the staff that put that information in as precisely as they could. Is there any? You can't put it in a little later? Or?
You can put it in later, right? So, and I go with the assessment schedule in a slide, but I don't want to go forward because I can't go back. So you have up until day 8 to set your assessment day, your first assessment, right? So a patient can come in on a Friday, and then you can still set your assessment up to day 8 and capture that information. But honestly, it starts pre-admission. So for admission coordinators, if there are any here, if there are hospital evaluators that you employ that are out there in the hospital, or if you're a physician or NP or you're in the hospital, getting the information to the SNF partner early, even pre-admission, so they understand what's their diagnoses, what conditions do they have, then skilled nursing facilities can take that and really be prepared to code, capture, get paid for, but also to be ready to care for that patient. So it really starts pre-admission. On the PTOT side, we did talk, they have a daily adjustment starting on day 21. So for Medicare's days 1 through 20, whatever category the patient falls into, that's what you get reimbursed. Starting on day 21, it drops by 2%. And then every 7 days thereafter, it drops by 2 more %. It's just that gradual decline based upon Medicare's research and what the stats show in terms of how much therapy they get. Not going to have a big impact on reimbursement. You're looking at $2, $3, maybe $4 a day drop in reimbursement starting on day 21. So it's not going to be too significant. And most of our patients on a Medicare Part A stay, based upon our company anyways, their average length of stay is about 24 to 27 days. So it's not going to have a huge impact on overall reimbursement. MDS completion schedule, I talked earlier that we have all these 5, 14, 30, all these different assessments today we have to do. That all goes away, and we have just really one required assessment upon admission, which is your 5-day, and you can set that assessment date from day 1 to day 8. And you have the ability now to set earlier assessments, because in some cases you might be able to look back into a hospital stay to capture some information for nursing capture and so forth. But you can pick any day from day 1 to day 8 to capture all the patient information you need for payment. And that could be the only assessment you need to do until the patient's discharged. You also have the option of doing an interim payment assessment. That's the only other payment assessment that's out there now, which is fantastic. It makes life a lot easier for everybody. And the interim payment assessment is basically if a patient has a change in status, change in condition, something changed while they're in your building that alters your plan of care, alters what you need to do for them, you can opt to do an interim payment assessment. It's not required, it's optional, it's up to you, but it's something that should be tracked. You know, maybe a patient comes in, they're on a regular diet, no swallowing issue. You know, on day 13 they have a choking episode. And now they're not swallowing properly. So now they're on an altered diet and they have a swallowing disorder that wasn't captured on admission. Look at that patient. You know, does that change their care plan? Does it change their reimbursement and their needs? Should we do an IPA, an interim payment assessment? The same thing holds true for all the different components. If there's a significant change and it alters the patient's status and you expect it to last for at least 14 days, then you can do an interim payment assessment.
How does this affect long-term care MDSs?
These are just payment assessments, so they don't impact the long-term care. In some cases, they can possibly be combined if there are some overs or that you may be able to combine an assessment, but these don't have. This is just for Medicare Part A, skilled stays
So
for
long-term care
payment.
assessments are as always.
As always,
Okay.
yeah. The last thing I want to talk about, I think, on PDPM and the brief overview is the type of therapy we can provide. They put a cap on group and concurrent therapy. So group is our ability to treat 2 to 6 patients at the same time. Medicare is concerned that since 30 minutes no longer drive reimbursement. Yes?
I'm sorry, I couldn't hear what you said.
Yep. So for the last couple changes under PDPM, one impacts how we can deliver therapy. It is currently today we can do group and concurrent therapy, but it impacts how we get reimbursed. So really we're not doing much group or concurrent therapy today with our Medicare Part A patients because it has a negative impact on reimbursement. Under PDPM, since therapy minutes no longer are relevant for reimbursement, Medicare is concerned that we're all going to just put every single patient in a big huge group and treat them all at once and, you know, kind of take advantage of the system, cut down on labor costs, make more money. So what they want to do is they want to limit how much group or concurrent therapy we can provide. Group therapy is a treatment of 2 to 6 patients at the same time doing the same activity. Concurrent therapy is a treatment of 2 patients at the same time, but they're doing different activities. So more for higher level patients that we can kind of, as a therapist, work on Mrs. Smith for a few minutes, pop over to Mr. Jones, kind of go back and forth. So Medicare says, you know, we prefer individual one-on-one care, but we recognize that there is a benefit to group and concurrent therapy for socialization, for getting patients working together and helping each other out. So they do want to reimburse for it, but they also want to cap it so we don't abuse it. So you will see in your facilities group therapy activity happening come October, I'm pretty sure. Patients love it, therapists love it if they do it the right way. It's a really nice mode of therapy, especially for patients who need a little motivation, a little, you know, help from their their neighbor to really participate fully in therapy. The interrupted stay policy is replacing the midnight rule. So now Medicare is looking at a 3-day window. So a patient leaves your facility for any reason and returns within 3 calendar days, you just pick up as they left off. Same PDPM group, same reimbursement. There's basically no break and spell. You just don't get paid if the days are not in your facility. But if the patient leaves your building for any reason and goes to another facility or is out of your facility more than 3 days, if they get readmitted, you start back at day 1. So there's pros and cons to this. You know, it does decrease some paperwork and compliance issues, you know, with the 3-day window that you have to kind of pick up where you left off. But also there's a reimbursement concern, you know, because if the patient comes back on day 3 before they missed 3 calendar days, then you pick up whatever Medicare day you left on. So if they left on day 20, and then they came back 2 days later, well, you're picking up on day 21, right? So you don't go back to the beginning on day 1, 2, and 3, where you get really nice non-therapy ancillary reimbursement. So there are some pros, some cons. And again, it doesn't make a difference if the patient goes home, goes to the hospital, has an ER observation stay. Where they go is irrelevant. It's all about 1, 2, 3. After 3 days, you reset the clock. Within 3 days, you don't reset the clock.
What if they have a significant change?
You
They
can-
broke their hip?
If they have a significant change, again, if they're back within 3 days, you can do a interim payment assessment to reclassify them,
Yep.
but it doesn't reset the calendar. So they still pick up on day, say 21, and you miss out. And the biggest issue is the patient goes out, say they go out with sepsis, right? And they come back and now they're on IV medication, but they came back to you within 2 days. You're not getting that nice pickup of non-therapy payment on day 1, 2, and 3, yet you might be on the hook for IV medications when they come back to your facility. So there's pros and cons. It does cut down on paperwork, cuts down on some of that issues, but it does have an impact on reimbursement.
Does that impact incentive to not hospitalize?
Well, yeah, and I mean, there's incentive there based upon your VBP. The whole rehospitalization measure that's going to have that payment incentive based upon this SNF PDPM program. So we're trying to keep patients out of the hospital, period. But this certainly does, have an impact. And obviously it keeps your census up. If you can keep a patient, treat them in-house, and care for them properly in-house, and keep that patient in your facility, well, then you're getting paid, not the hospital, right? So definitely does increase that incentive. Okay, so for me, PDPM does change the focus of how we have to look at our patients and clinically what we got to do in our facilities. So again, this is all based upon patient characteristics, not service provision for therapy. So program development from a clinical perspective is critically important. You want to be able to care for clinically challenging patients. The more challenging the patient, the more medical complexities they have, the more diagnoses they have, the better they reimburse. If you can develop clinical programs to care for cardiac, respiratory, wounds, diabetics, whatever it may be, and get good outcomes and be clinically efficient in how you deliver care, you'll do very well under PDPM. Documentation across all disciplines is very important, because every discipline, PT, OT, speech, nursing, non-therapy ancillaries, they all increase or they all contribute to reimbursement. Right now, today, therapy gets hammered by Medicare on documentation audits. It's just the way of the world for the past 10 years, at least, because every single Medicare day is being reimbursed at a therapy run. Now they're going to look at all documentation, and they're going to look at it very closely to make sure that what you're billing is supported by what you document.
Does that apply to physicians and NPs as well in this model?
Yes. It actually, for me, it kind of increases the importance of the physician involvement with payment on many levels, and we'll kind of get into that. But so much of this is dependent upon diagnoses, active diagnoses, ongoing monitoring and care by nursing services. So the ability for our physician partners and groups to come in, assess, diagnose, document good, solid H&Ps that allow us to then code and capture is going to be critically important. And that ongoing kind of monitoring of the patient and ensuring that they still need medical necessity and care in a SNF.
So can they use the documentation from the hospital with
Yes.
the diagnosis?
So long as you have it in your medical record.
Yep.
And but again, taking that and then having your physician groups go through there and kind of doing their H&P and exams upon admission and ongoing as needed is going to help support all of that. But yes, you can use any, and that's where the pre-admission piece really comes in critical. There's certain, like, you want as much info from the hospital, from all the discharge summary information, all the consults they got, all the therapy notes if they had therapy, whatever you can get from the hospital,
But it has to be in the patient chart, in the facility,
you have to have a record of it.
not just on him or
It has to be part of your patient's medical record.
print it, put it in.
Yeah, if it's, if you're still paper, then it has to be paper. If you're electronic, it has to be part of your EMR. But yeah, you have to have it, because when you get audited, Medicare is going to want to see that you have supportive documentation for whatever you're billing back. So coding expertise and accuracy is going to be very important. You don't need to hire certified billers, coders in your facilities to do all this. They just need to know what PDPM is, what drives reimbursement, so they know exactly what to look for, and you should be fine. It reinforces Medicare's goal, triple aim, better care, better health, lower cost. And really, for me, it really looks at what's the outcome you're achieving for your patients, and the use of care pathways to get there. For therapy, for nursing, is going to be more important now under PDPM. I'll just quickly go through all these. Taking too long on this part. Medicare is very concerned if providers change behavior. If we start limiting therapy, changing how we code for depression, changing how we code for cognition, changing how we code for swallowing, Medicare is going to look at that and say, all right, now they're just changing how they code to increase their reimbursement. So Medicare is very aware of this, and they really want to make sure that whatever changes in behavior they see are supported and documented. If they do audit and take a look at your facility and you're coding cognition for a patient, well, you better have the BIMS completed, the brief interview for mental status, and it better indicate that the patient has a cognitive impairment. They're going to go out there and do that. John Kane from Medicare has been very blunt that they do expect some provider behavior changes. They're not going to look at it kind of in a vacuum. They're going to look at the whole picture. What's this facility performing like? What are the outcomes? What are their quality measures? What's their readmission rate back to the hospital? What's their patient satisfaction scores? How are they looking on their SNF QRP measures? And if they're looking good there and they still see provider behavior changes, not that big a deal. But if your facility is not performing well, having high readmissions, poor quality measures, and they see these big provider change behaviors, you're going to get audited. He's been very blunt about that.
Is there any accommodation for increased payment based on supermorbid obesity?
Super morbid, just morbid obesity
Morbid
increases
alone?
your reimbursement. It impacts your NTA. It gives you like 1 or 2 points on your NTA, and we'll show that in a minute.
Okay.
And so it gives you some increased reimbursement. I'm not even sure what super morbid obesity
It
is.
means a bed for a 600-pound patient,
Okay.
or a special wheelchair,
Yeah.
or 3 CNAs to turn them.
Gotcha. So just morbid obesity counts. Yep. All right. So moving along to ICD-10 coding. This is where it really gets critically important in terms of how we code and capture. And you probably hear me say, identify, code, and capture 100 times. Identify, code, and capture. That's the critical part with ICD-10 coding. Identify the diagnoses, find the right ICD-10 code, capture it on your MDS. It does impact to some degree all 5 case mix adjusted components under PDPM, so it really is critically important. And more importantly, it does paint for Medicare the picture of the patient. When they're not looking at patients in your facilities, right? They're looking at what you submit to them on your claims data, on your MDSs. And the coding really lets them know that this patient requires SNF level of care. Coding act, I already said that. Good. So, new items for the MDS to help with the coding process. We're looking at 2 different areas, Section I of the MDS and Section J. Section I is the section where we capture SNF primary diagnosis. So why is the patient in the hospital and now coming to your facility for SNF level of care? And this is where the team has to get together and determine what's the appropriate primary code to put in that section, because you have 1 chance to catch it. There's a new item on the MDS called Section I0020B. Whatever ICD-10 code you put in that section is going to determine your clinical category for reimbursement for PTOT. It has to be a very specific ICD-10 code. It then gets mapped to a clinical category, and it determines your reimbursement. And to some degree, it determines your reimbursement for speech therapy as a primary diagnosis. There's one other way you can get a clinical category, and that's using Section J, which they've added different sections to the MDS. And this is talking about the patient's past surgical history. It has to be a surgical procedure that happened in the prior hospital stay. So we're not looking at surgeries from 2, 3, 4, 5 years ago, or even 3, 4, 5 months ago. It's the patient's in the hospital. If they had a surgery and then came to you, you can code and capture that in Section J under very certain sections. And you can get credit for that, and it will map to a certain category for reimbursement. What's nice about this part is you don't need this specific ICD-10 code or the procedural code on the MDS. It's really, they're check boxes. It's orthopedic surgeries, cardiac surgeries, and there's different options, but they're simple check boxes to get credit for it. These are the PTOT clinical categories, so there's 4 of them. You have medical management, other orthopedic, non-orthopedic surgery or acute neurological conditions, and then major joint replacement or spinal surgery. So depending upon what ICD-10 code you pick or what Section J surgical procedure is identified, it'll map to one of these 4 categories. Each of these has subcategories, so there's like 10 different whatever subcategories. So under medical management, you have all of your acute infections, and sepsis would fall under medical management, cardiovascular issues, pulmonary, all of your cancers, and then just a big bucket of other medical management type of diagnoses. So you have a huge range of conditions that patients have that fall into medical management, and the vast majority of our patients are currently falling into this category for reimbursement. Under other orthopedic, it's really just orthopedic surgeries, unless it's a major joint or spinal surgery, and then any non-orthopedic condition, any non-surgical orthopedic condition or musculoskeletal type condition. Under non-ortho surgery, acute neurologic, it's just those two areas. If they have any type of surgery that's not an orthopedic surgery, you'll fall into this category. If they have an acute neurological condition, CVA, TIA, those sorts of things, they'll fall into acute neuro. And then major joints and spinal surgeries are simply major joints and spinal surgeries. So that's that. And from a reimbursement standpoint, these only impact PT/OT, right? They also impact speech, but these four categories only impact PT and OT. They don't have a negative impact on nursing. Major joints pay the highest, followed by other orthopedic diagnoses, followed by the non-ortho acute neuro, and then medical management has the lowest CMI and lowest reimbursement. So what we've been educating our folks is if you can capture a patient in any category other than medical management, do it. As long as it's appropriate, as long as it meets criteria and compliance, it has by far the lowest reimbursement. And the vast majority of our patients today are falling into that category, and it's having a negative impact on reimbursement. Medicare has fantastic tools on their website. One is the ICD-10 code mapping. So this here kind of quickly shows you what's the ICD-10 code, the description of the code, and what clinical category does it default into, right? And this becomes really important. I was talking to a consultant on my way up here today, and what they're finding as their folks are starting to look at PDPM and put the right diagnoses on the MDS to get them to a clinical category, there's a ton of return to provider codes. So Medicare has said, hey, if this is the patient's primary diagnosis, like say dehydration, bradycardia, certain infections as well, they look at those, they say, all right, just because they have this diagnosis, if this is the primary condition the patient has, then they don't need a Medicare Part A benefit in a SNF, right? So dehydration is return to provider. So if you put that into your MDS as a primary diagnosis, you're not getting paid. And this is something that, again, pre-admission in the hospital, having this information of what's the hospital coding, what's the diagnoses that we have, is it going to qualify for a Medicare Part A skill in a SNF? And that's where coding becomes critically important. Questions on that? Yep.
So you're saying that we should basically ask ourselves, why is this person in rehab, not home?
Correct.
And whatever that diagnosis is becomes the primary, everything else secondary.
Correct. Yep.
How do you think the patients are going to fall out in all of this?
Fall out in what regard?
They're going to be caught in between sometimes, especially early on, trying to figure out what's going on. Do you have a sense of what patient advocates are saying about all this stuff?
It's a great question. I think it's going to be one of those that is going to evolve over time as folks become more acutely aware of how the coding impacts the patient's ability to tap into the Medicare Part A benefit. Currently today, patient goes out to the hospital, they have a 3-day hospital stay, and they say, all right, they need therapy, they come back to the SNF, and they're covered. Under PDPM, you got to look at what are the specific characteristics and ensure that patients are going to be covered. I think the vast majority of patients will still be covered, but there will be a handful that maybe today could be covered that won't be covered tomorrow, and that can have an impact. If they can't tap into the Medicare Part A benefit, how are they going to pay for a skill stay if they need it, right? And that's something that we have to work through. And I belong with an advocacy group based out of DC, and there's things we're looking at and trying to see how it's going to play out and roll out as we transition into it. I think most providers will find a way to make it work. And working with your hospital partners is going to be important. Really having them knowledgeable about, we need this information. It's not just for payment, it's so that your patient can get the right care in a skilled nursing facility so that they can go back home and not have a readmission back to your hospital, which then penalizes the hospital on their VBP program, readmission program. So it's really that partnership between your upstream hospital partners as well as your downstream home health partners to make sure that we have good transitions and that we can get patients qualified for their stay. Because if they don't qualify for a SNF, they have to go back home, then home health is going to be burdened, caring for a much sicker patient than what they're used to. So that's something we're monitoring, and we'll see, but it's going to be interesting to see how it plays out. That's the, so this is, we talked about the clinical category. This is the ICD-10 code mapping for your non-therapy ancillaries. So you have the comorbidity or the non-therapy ancillary description, what the ICD-10 code is, and then the description of the code. So again, having the condition is fine, but you have to find the right ICD-10 code to get credit for it. And I have a little bit more on this in a couple more slides. Speech is impacted heavily by diagnoses and ICD-10 coding. So we're looking at number one is your clinical category. Speech has two options. I just talked about PTOT, they have four. Speech only has two, acute neuro or non-neuro. So based upon what you put in section I0020B is going to map them to acute or non-neurologic. But more importantly is this whole comorbidity list here. These are all conditions or diagnoses the patient has that are active but part of their past medical history. And if they have those, they may be likely to need speech therapy services while at your facility. So maybe they fell and they had that hip fracture, but underlying they had an old CVA. And because of that CVA, they have some dysphagia. So even though they're in your building recuperating from a hip fracture, that acute onset, that acute injury, may have triggered a relapse or kind of exacerbation of dysphagia. And they're going to need speech services, right? Speech don't really treat hip fractures, but they do treat dysphagia. So, Medicare came up with this whole list of comorbidities that if a patient has one of these, it'll impact reimbursement. And it impacts it significantly. Could be anywhere from about $17 per Medicare day if they have just one of these conditions. So they're aphasia, CVA, hemiplegia, TBI, trach, and vent. The list on the left in black, those are simple checkboxes on your MDS. So if they have it in their medical history, it's still an active issue with some type of impairment impacting their current function, you can code and capture it with a simple check on the MDS. The ones here on the right in red, these all require a very specific ICD-10 code. So just because the patient has dysphagia doesn't mean it qualifies as a comorbidity. It has to be related to some type of CVD, right? So there's like 4 or 5, Jen, how many 4 or 5 different codes that qualify for dysphagia? So you have to identify, yes, they have dysphagia. Is it related to a cerebral vascular disease? If it is, you can code and capture it. And all these here, the laryngeal cancer, apraxia, dysphagia, ALS, oral cancer, speech language deficits, require very specific ICD-10 codes to get credit for it. Okay. And this here is kind of a partial list of showing like apraxia, right? You have to enter the ICD-10 code. It needs to be I69990, right? Apraxia following unspecified CVD. So it's important to know what these are and that we identify, code, and capture them in order to get credit. And all you need is one comorbidity, identified, code, and captured on the MDS to get your reimbursement. They could have 4 or 5, and that's fine. You can code all of them, but only one is required to get reimbursement. Questions on that? Once, twice. So financial impact on coding. So I gave an example. So PTOT, again, is impacted by function, impacted by diagnoses. If you take a patient who has a functional score of 0 to 5, so this is a very dependent patient who needs lots of help and support for mobility and self-care. If they fall into medical management, you're going to get reimbursed $131 a day. If they fall into other orthopedic, you can get reimbursed $162. So $30 per day difference in reimbursement, depending upon how you code the patient. If you have an option of coding medical or other orthopedic, and you chose medical, you're losing $30 a day. And then as the functional score changes, the reimbursement changes as well. And this is where PTOT get complex because the CMI scores are all over the place. I don't want to get into that, but you can see if the patient is a 10 to 23. So that's kind of a mid-assist patient. They need some help with self-care, some help with mobility, but they can get up and move around a little bit. Again, the reimbursement difference is $14 a day based upon how you code the patient. So a significant reimbursement that we're going to see based upon how we code. On the speech side, it gets, like I said, a little more complex, but a little bit more straightforward. The more you can code and capture, the higher the reimbursement. So looking at it here, speech is done 2 ways. You have column 1, which is that the patient have an acute neurological condition, a speech comorbidity, or a cognitive impairment. You determine they have none, 1, 2, or 3 of those, right? And then you go to column 2. Are they on an altered diet, or do they have a swallowing disorder? It's either, neither, or both. But for purposes of this financial example, we said, all right, the patient has no altered diet, no swallowing disorder. So really just try to focus in on what impact does coding have on reimbursement. So if you don't code anything and they have no swallowing issues, you get $15 a day. This is federal base rate, so adjusted for your locality. If you can code one of those, an acute neurological condition or a speech comorbidity, it jumps up to $32 a day, and now $17 per day difference. If they have both those conditions, a comorbidity and an acute neurological condition, it jumps up to $45 a day. So now you have like another $13 per day difference in reimbursement. So the ability to code and capture multiple conditions for speech increases reimbursement exponentially per patient day. So critically important that we understand these and capture them.
Can I ask an example? Somebody comes in with aspiration pneumonia.
Yep.
No previous history, gets septic, stays in the intensive care unit, gets debilitated, has some delirium. The delirium starts to clear when they're ready to be discharged. There's no permanent cognitive impairment. There's no specific cerebrovascular disease. Yet the whole focus may very well be on speech therapy.
Yep.
For aspiration. How would something like that fit in?
So looking at diagnosis codes, they have to be active. And there's a definition of that in the MDS manual. So diagnosed within the last 60 days, but having issues in the last 7, right? So the delirium, if they're still exhibiting symptoms while they're in the SNF and it's impacting their cognition, it may still qualify, right? It may resolve over time, but it all depends upon when you assess and what you capture at that point. The aspiration piece, is that causing them to have a swallowing disorder? And there's 4 specific questions on the MDS to speak to that would determine if they have one or not. It's not just a matter of having a diagnosis of dysphagia. Are they having pain while swallowing, leakage or spillage from the mouth, coughing? There's one other I'm drawing a blank on, but 4 specific questions on the MDS. If they have one episode, one time in your assessment window, they have a swallowing disorder per Medicare. And then if they have aspiration pneumonia, are they on an altered diet while in the facility? Could be liquids, could be solids, could be both. So then in that case, if they had both an altered diet and a swallowing disorder, it would increase the reimbursement substantially. If they had a cognitive impairment because of their delirium, then that would also add to the reimbursement. And it all depends upon when you identify it and when you set your assessment day. And this is going to be the tricky part, because that patient, if they come to us and they're still recovering from their delirium and having some of these issues on days 1, 2, and 3 of the Medicare stay, but then they're resolved on day 5, 6, or 7 and no longer have them, we're still getting paid for it. There you go. Yeah, so he's pulled up for me. Loss of liquids, holding food in the mouth, coughing or choking, complaining of pain while swallowing are the 4 different questions on Section K of the MDS. So it's really about identifying and coding it while it happening in that 5-day window. Answer that question, hopefully. Preparing for coding, really understanding the importance of coding across the 5 case mix adjusted components. We gotta get going here. How many doing on time? Running along, I think.
We have 10 minutes.
10 minutes, okay. So what I want to talk about today is that physician involvement, the last piece here. Obviously, you got to understand coding, know the crosswalks that are available, look at your EMR for a solution, but look at the hospital referral sources and your physician involvement are 2 key areas when we start talking about diagnosis and coding. They need to be educated. You need to partner with your referral sources so they understand what you need from them so that you can appropriately care plan for your patients and get paid for your services so you can afford to care for the patients they're sending you. I want to get into NTAs. We'll skip that. Really, NTAs, why is it a whole new payment component under PDPM? It's really to pay facilities and entice them to take challenging patients, expensive patients who have complexities and conditions that cost a lot of money to care for, that today you might say, no, I can't afford to care for that patient because they're on IV meds and there's no specific reimbursement for it. It's just I can't cost it out and try to profit or at least break even. NTAs is designed to allow you to take that type of patient. Classification, it's a simple scoring process. The chart over here is just a small list of some of the conditions and services. So you talk about HIV and AIDS, would be 1, and that gives you 8 points. IV medications are on here somewhere. Boom, 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 boom. Parental IV feeds, if you have feeds that are a low level, high level, you get 7 points or 3 points. IV medication while in your facility, you get 5 points. Immune disorders, you get a point. There's a whole active diagnosis, asthma, COPD, chronic lung disease, you get a couple of points. So all these conditions and services, there are about 60 or 70 of them, all told, all have point values. You identify, you code, you capture on the MDS, and you get to a scoring range. It can go from 0 if you don't capture anything, and on up to 12 plus at the high end. And start looking at your daily unadjusted reimbursement. If you don't capture any complexities or any conditions and services, you're still going to get paid $173 a day for days 1, 2, and 3, and it drops to $58 a day on day 4. But if you can code just one area, it jumps up to $231. If you code, if you get 3 to 5 points, it jumps up to $323. So if you have a patient on IV medication, right, that's worth 5 points. More than likely, they have some type of infection or wound or something that you can also code and capture. But at a bare minimum, IV meds are going to get you $323 a day for days 1, 2, and 3, and an additional $107 a day starting on day 4. And more than likely, that patient's going to qualify for the higher category at $450 a day. So long story short, the more points you can capture, the higher the scoring range you can achieve, the reimbursement is significant. Some of these rates will be downward adjusted for Maine based upon your geography and how Medicare reimburses, but still significant reimbursement. So we kind of just went through that, but the daily impact on reimbursement, you have the slides, you can look through this on your own, but as you code and capture more and more, you're looking at $56, $88, $120, $160 a day of increased reimbursement. And looking at the course of a length of stay, if a patient's in your building for 15 days, you know, you could have additional revenues of $400, $600, $800, $1,000, $1,100 a day, depending upon what category they qualify for. If they're in your building for 30 days, you're talking even more revenue, depending on how well you can code and capture. When I looked at the NTAs and looked at all the different conditions that qualify, these were the 5 different areas that I thought are good clinical programs, that if you can treat these types of patients and treat them well and efficiently and get good outcomes without kicking them back to the hospital, you will do very, very well under PDPM. Patients with sepsis, all these infections, because they might need IV meds, there's all these different conditions that qualify under NTAs that would drive up reimbursement for patients who typically have sepsis or have sepsis. Respiratory is a huge one. If you do have the ability to care for trachs, vents, and do suctioning, they're all worth some points. COPD, asthma, respiratory arrest, all different conditions that drive. Wounds, a lot of patients on wounds might need IV meds, and there's a whole bunch of wound infection and wound codes for unhealed ulcers, diabetic ulcers that would code and increase reimbursement. Same thing with diabetes, lots of different diabetic areas from retinopathy to ulcers and to just having an active diagnosis of diabetes. Because that also puts you into a really good nursing category. I forget if special care low or special care high, one or the other, but it's one of the higher reimbursement for nursing if they have active diabetes with med changes and insulin injections. So it increases your NTA, also increases your nursing, and all these different ones here for medical management. So preparing, it's looking at, first understand that NTAs are, for me, the most important reimbursement driver under PDPM, because currently today it's irrelevant for reimbursement, but it's going to be significant under PDPM. Looking at the capture process, who's responsible, who's part of the team to make sure we code, identify, code, and capture everything. Look at that crosswalk I talked to you about on the cms.gov website. Looking at your clinical programs in terms of what we just looked at, sepsis, diabetes, wounds, infections. Do you have the right staff? Are they competent? Can you care for that kind of patient and get a good outcome? And then again, look for your EMR solutions, but your hospitals and your physician involvement, especially if you're getting more complicated patients who are more acutely ill with more conditions and complexities. We in the skilled nursing industry have to up our game. Be able to care for these patients and care for them well to, again, get the right outcome. It can't just be about chasing the dollar. You still want to do that, but you got to do it the right way to get the right outcome so the patient has a good outcome. You have this, these are just some of my kind of keys to success under PDPM. You got to look at management, compliance, outcomes, and clinical. And we don't have time to go through all that today. I do want to show you this. So early results. So like I said, we've uploaded about 350 to almost 400,000 Medicare days into our system. What we're finding in terms of capture, right? So PT and OT are impacted by clinical category. Oh, don't do that. 66% of our days are falling into medical management. That's 2/3, right, of our days are falling into here. Has the lowest reimbursement for therapy. So that's problematic for reimbursement. 11% in non-orthopedic surgery, 19% in other orthopedic, and just 3% in major joint or spinal surgery. I think that's going to jump up a little bit, not because we're seeing lots of joints in our facilities, but we are seeing spinal patients that just aren't being captured today. So we're advising folks, hey, if you can get them out of medical management, try to get them into something else, you're going to do well financially. Functional score, in terms of reimbursement, 0 to 5 pays the lowest for therapy with the highest for nursing. And we're seeing 12% of days captured there. 10 to 23 pays the best for therapy but the lowest for nursing, and we're seeing most of our days there. So again, there's some interplay between nursing and rehab in terms of reimbursement based upon function, but it kind of is what it is. Patients, as long as you're doing accurately, it's going to fall where it needs to fall. NTAs. So 0 NTA points is 38% of our current Medicare days. That's hugely important. 0, that's the lowest CMI, lowest reimbursement. It's killing facilities. That 38% are at the 0, and another 36% are at 1 to 2. These two categories, they're NF and NE, pay the lowest. They're negative CMI. No, their CMI is less than 1. So you take the federal rate, you adjust it down, based upon your locality, and then you adjust it again downward if they fall into the 0 or the 1 to 2 category. And that's about, 74% of our days are falling into those two categories. And once facilities figure this out and they start moving patients into higher reimbursing categories, it's going to have a huge impact on their reimbursement. Depression capture, we didn't talk a lot about depression, but depression impacts 3 of the nursing groups, and it has a huge impact. You're talking about $30 to $40 per day of reimbursement if you capture depression or not, right? So 97% of the days are not capturing, 3% of the days are capturing. I read the REI manual, and Medicare says they're, this is not a direct quote, but pretty close, is that mood disorders and depression are common in skilled nursing homes and are undercoded and underdiagnosed and undertreated. You know, Medicare's, they put that in their manual on educating us, that they believe they were undercoding depression, and I would say that 3% is undercoded. And it's not that they have depression, it's that they have depressing symptoms of depression. They're in your facility, they have certain conditions or certain feelings and moods based upon the PHQ-9 that indicate they have kind of situational depression or just symptoms of depression. And then finally, on the nursing coverage piece, 38% of the days, this is actually, I need to adjust this with new data, 26% of our days currently don't have a nursing coverage for a SNF, meaning they fall into the 2 lower nursing groups that don't provide presumption of coverage. So it's low reimbursement, but it also says, based upon how you identified and coded this patient, they don't need to be in a SNF for nursing care. So then it falls on to do they need therapy. So it's a huge issue that we need to address. And finally, speech, because speech has 5 different areas. Diagnoses, we're seeing 11% of days captured as acute neurologic. Cognitive impairment, surprise, is pretty high. 55% of the patients are intact, meaning 45% in total are not intact. So that seems to be fairly accurate based upon my knowledge of skilled nursing patients. About 45% might trigger for a cognitive impairment. The speech comorbidities, we're looking at 14% of patients are being coded today with a speech comorbidity that will qualify for reimbursement. And this is the piece that always cracks me up. Altered diet, 22% of patients, based upon the MDS we've analyzed, have an altered diet, yet only 3% have a swallowing disorder. It's undercoded today, swallowing disorder. Again, it's those 4 little questions on the MDS Section K. Whoever's completing that in the facilities just isn't looking at the whole picture of the patient. That number is going to jump up significantly, and it's going to add anywhere from 13 to $22 a day of reimbursement once folks understand how to code it properly. So what can you do? What should you be doing today? If you're not already, start entering or completing your MDS as if PDPM were in effect. We have to get in the process of looking at all these codes, all these conditions, get them on the MDS so that we have all that practice done out of the way before October hits. Understand all the different payment determinants across the 5 case mix adjustment components. Auditing. Audit all your medical records to make sure that it's whatever you're coding is supported by documentation, by diagnosis, by physician, by nursing, by therapy. It all has to be there. And these are, this is the kind of the link to the PDPM webpage for CMS, and it has all these great resources on the, they have a classification walkthrough that kind of takes you step by step how to categorize a patient, all the crosswalks where you're coding. Really important that your admissions folks and your evaluators get access to this so that they can start looking at, all right, the hospital is saying the patient has this diagnosis. What does it look like? You know, what's it going to categorize the patient as? Is it a return to provider or is it a viable code? And then you have the crosswalks for the NTAs, for the speech, and nice little fact sheets that kind of go over what I talked about today. That's us. That's not us personally, but that's a nice picture that our marketing person put on there. I wish I had that much hair, but I'm more like that guy. So, questions? Covered a lot in a short period of time. I apologize for kind of trying to cram it all in, but you have the slides, you have my contact info. We're in this area.